Hey, Muyi.
Hi there.
How are you doing?
I'm good. You?
Good.
Good to see you.
Good to see you. All right. So you're a researcher. Tell me more about that, please.
So my name is Muyi. I'm a research methodologist at the Center for Advancing Health Outcomes. I'm part of Amy's team. My role is to work with the numbers, specifically quantitative research, trying to count outcomes, look at how people are doing in terms of, for example, residents' quality of life. I've specifically been focused on the baseline, trying to understand how people are before they move into the new home, and then hopefully be tracking that over time also to see whether or not we experience significant changes.
This is really fascinating. So maybe from the balcony, a high level, tell me about systems change here.
Over time, we have studied systems change, what we call systems transformation. While it is possible, it requires willingness to try new things, but also willingness to follow the data, and a willingness to abandon ship when pieces of the change don't happen, the way we want it to.
What surprised you? What's been a surprise for you out of the data?
So I would say that this time we're mostly looking at baseline data. I say baseline to say, this is where we are currently. We will be moving with the residents into a new care environment, and we have various hypotheses. We hypothesize a number of changes will happen. If you take them to a home where they're able to express their own will, able to have a sense of control, are able to go outdoors and enjoy, the weather, for example. It's a nice day out, what does that do for people's mental well-being? And so that's the piece we're trying to explore now.
I'm old enough to know that in any changing environment, it's not necessarily all that fun.
Yeah.
What's been the impact on staff with this new way?
I would like to think about the old way and then think about the new way. So the old way we would like to describe as more task-oriented, where, for example, the care aides will come into the home at the start of a shift and would have a number of residents assigned to their care. And then for those residents, they would have a number of tasks to be done for them. And what we noticed as a team was that care was largely driven by the system. So for example, you come in at 7 a.m. on a morning shift, you start with the early riser, so trying to get them ready for the day. That's a rush because you're trying to get them ready for an 8 a.m. breakfast. And by the time you're getting those guys ready, you're already prepping for the lunch, which is, midday. But this new model is more focused on, having residents direct what will happen on a day. So it's not necessarily getting people up to do the tasks for the days when people want us to do that.
It sounds almost like, and I don't want to push the metaphor, but home for us is home for the residents and home for staff.
Yeah. So I think the way the team tries to think about it is not just, it's really three main groups. It's the residents, it's the staff, but it's also the people who frequently visit the home. How's experience for them? And these are the outcomes we're trying to track.
What's your hope?
I would say that when I've been involved with this now for quite a while. When I first heard about the initial iteration of the project, I was at that time intrigued. It is really difficult to be a care aide in long-term care. It is really a tough job. And so when you hear about health worker issues, I can sort of understand. So I'm rooting for them. You can see that they really want this. My hope is that long-term care becomes a lot more pleasurable and pleasant.
Well, thank you very much, Muyi. I've really enjoyed this conversation, and I've been engaged.
Well, it was nice talking with you.
Thank you.
Thank you.